to go ahead and to introduce our speaker so we can give him more time for tonight. Dr. Mehrdad Razaghy has an extensive background in research beginning in 2014, when he spent a full year focusing on multiple projects in the field of neurosurgery. He was part of 6 major publications at David Geffen School of Medicine of UCLA, with a focus on spinal cord diagnostic and motor dexterity. His passion for creation and research carried through his path in dentistry and allowed him to be involved in various research projects. His journey in dental research began by joining Dr. Pascal Magnier Research Laboratory at Herman Ostrow School of Dentistry of USC. Since then, alongside teaching, he has been part of multiple research and clinical projects under close mentorships of Dr. Pascal Magnier. Together with his mentor, Dr. Razaghy has contributed to various books, journals, and publications in the world of restorative and biomimetic dentistry. Dr. Razaghy has been part of publications in the esteemed Journal of Dental Material and International Journal of Aesthetic Dentistry, and currently practices general and restorative dentistry in Los Angeles. Besides mentorship of a few selected students, he is an active lecturer in the US and currently teaches multiple CE modules in the fields of dental photography, additive dentistry, digital smile design, rubber dam isolation, and bonded porcelain ceramic restorations. Without further ado, may I introduce you Dr. Razaghy.
We're going to start now. I wanted to start by sharing my sadness for not being there in person. My sincere apologies. One of the wings of the flight got canceled, and we had perfectly planned this so that I can arrive back in Los Angeles tonight. And I was very excited to be there in person. I love in-person lectures. Just the level of interaction is what makes it very special. Unfortunately, flights got canceled, and now I'm really excited to really share all the information I put together for you. And really, I have to say that the topic that we are talking about is something rather challenging to cover in 2 hours. This is the most amount of information I've ever presented in 2 hours. I really wanted everyone to have a very nice understanding of what we call the biomimetic checklist at the end of this lecture. And we're going to talk a lot about resin and basically composites and bonding agents and additive treatments. And we're going to touch on fiber reinforced composites. And we really want to change the way you treatment plan additive resin composites and just give you reminders of what are the things we can do that makes our everyday composite diagnosis and composite treatment extremely reliable and extremely predictable. We're going to also talk about additive anterior composites, and we're going to touch about the role of resin in bonded indirect restorations. As you know, all of this is a lot to touch on in 2 hours, but I really worked hard to put together this checklist, and my goal is that by the end of this 2 hours, you have a very nice understanding of everything you see here on our checklist. And don't worry, this checklist will be repeated again and again throughout the lecture. I know this lecture will be recorded. Feel free to take pictures and take photos. The one thing I ask is that on all the slides where you see faces of patients, I ask that you do not take photos or take screenshots. I do have consent to share their faces, but just for extra privacy, I would love it if you can avoid that. This, what you see here, is the research lab of Dr. Pascal Magnier in USC School of Dentistry. It's located in the basement of the school. I spent most of my weekends and most of my nights at this research lab when I was a dental student at USC. And that's really where Dr. Manier shared his passion of biomimetic and restorative dentistry and basically dental materials with me. And that's when I got hooked. And if you've ever been around Dr. Manier, you know that his passion for dentistry is very contagious. And it definitely is and was the reason why I am in dental education today. And I'm very happy to remotely be here with all of you tonight. And I really hope at the end of this lecture, you say that it doesn't matter if you didn't make it in person, we learned a lot. This is Mani Education, and it's so exciting for me to have Dr. Mania back. This is basically a miracle that's happening in this facility next to our clinic, what we call Mani Education. It has many modules that really goes into all these topics that we're going to talk about today. This is the most comprehensive, hands-on and lecture education I've ever witnessed. Dr. Mania put together and all ran and initiated and invested in by our CEO, Mr. Sam Alawi. If you have questions about the modules that are provided at our education center, please, at the end, I'll provide my email. Shoot me an email. Usually the drill with me is that anywhere I lecture, if any of our students are interested in being part of these modules, we offer them special pricing. So hit me up if you're interested, and I'll be happy to walk you through it. Let's start this lecture by the definition of biomimetic dentistry. We've seen this word around, and at least we've heard of it, but I've seen rather very complex definitions of biomimetic dentistry. And I wanted to start by saying that it's really not that complex. This is a very simple concept in dentistry for me. And it really all starts by simply appreciating nature. If you look at natural teeth that are untouched, and if you look at your young patient's beautiful teeth, and that gets you excited, that is enough to say that you're a biomimetic dentist. And really, this brings on the value of preventative dentistry. Nothing will replace nature like itself. And if you have appreciation for the natural dentition and the natural tooth, your obsession with crowns and zirconia and ceramics and stronger materials will slowly fade away. And you'll understand the value of doing the type of dentistry where you don't even have to remove this beautiful tooth structure to begin with. And that's what I mean when I say that true biomimetic dentistry is preventative dentistry. And when the time comes for tooth replacement, then really we have to start with our most additive, least reductive solution for everyday dentistry. And that's why we're going to spend a lot of time today talking about composites. Composites today happen to be the most minimally invasive, or I should say, the most additive solution in our everyday dentistry. And I say that simply because anytime we are able to do composite restorations or additive dentistry, we simply tend to remove less and less tooth structure. The more we move towards indirect restorations, whether it's zirconia, emax, feldspathic, even milled composite, we have to deal with those concepts of path of insertion. the concepts of minimal thickness. And for those reasons, we tend to remove more. So we want to take slow steps towards that level of dentistry and understand why composite is the way to go. Now, let's ask ourselves this question. What is the problem? What is the big problem with large composite restorations? And that really comes down to what composites are made of. What is it that makes us question, wait a minute, I really think I need to do an Emacs onlay. I really think I need to do an Emacs overlay and not do a direct restoration. And you're thinking right most of the time, because the big dilemma in additive or direct composite restoration has always been shrinkage. When we light cure composites, they go through this phenomenon called post-polymerization shrinkage. And that's simply because of these components that are in most of composites, which are mostly the reinforced fillers, and that some combination of chemicals that create this shrinkage, or what we call polymerization shrinkage, after you light your composites. That's why when we do large composite restorations, sometimes we could harm the tooth because of these shrinkage forces and post-polymerization shrinkage cracks. And that's why sometimes we see sensitivity when we do a large MOD or a really big direct composite restoration on posterior or anterior teeth. Let's understand what is this shrinkage. So on the right side, you're seeing a very close-up electron micrograph of this bisection of where our bonding agent is fusing our composite and dentin in this case. And this is very nice to look at, because what you're seeing here is a separation. All these gaps happened after you cured the composite, and the composite was so big that it pulled itself towards the center of the restoration. Now we are left with these gaps between our bonding agent, our hybrid layer per se, and our dentin. And this is where these large composites could become problematic. Now, let's look at one of the teeth we were having fun with in one of our research projects here. This is rather a very big preparation. It's a 5x5 preparation. And I want to use this sample to really define this concept of C factor. What is this C factor? Let's look at it. Imagine we do a big composite here, a big MOD composite. What polymerization shrinkage is basically, imagine a dot right in the center of your restoration. Right after you polymerize this composite that you placed on, after all your layers are done, all of these surfaces will start to shrink towards this very middle point of your restoration. That's why when you look up the formula of your C factor, in the formula, we have number of surfaces. The more number of surfaces you have, the higher the C factor. But we have to call it the volume factor, because the bigger the volume of this composite, the bigger and stronger the C factor. And this is the problem that we're dealing with. I want to walk you through a very interesting study that we did together with Dr. Pascal Magnier in our research lab back in USC. This was a continuation of this curiosity we had in how can we solve this problem of C factor? How can we solve this problem of shrinkage? And in Dr. Magnier's research lab, together with his previous scholars, they had tried everything. They've tested layering, doing 7 layers, 12 layers. They've tried the closed and open sandwich techniques. But what we found in this specific research was something very exciting, something very different than what they tried in 2013 and 2016. First, they tried layering, and of course, the gold standard has always been the CAD/CAM restorations. Nothing after layering. And then they started incorporating a resin-modified glass ionomer and glass ionomer as dentin replacement. They saw a lot of improvements in shrinkage-induced cracks, but still the fatigue resistance of these restorations was not enough for us to be comparable to indirect composite. And in this study, we found something very exciting and different, and I wanted to share that with you. So just like all the other studies in the past studying shrinkage, we start by measuring our teeth. These are extracted teeth and coming from first floor oral surgery department at USC. One of the reasons why I really liked extractions because I was constantly looking for these beautiful teeth, and most of them unfortunately came from patients with periodontal disease that were losing these teeth anyways. So we start by measuring the size of these teeth so we can have the same size, medium, large, small, distributed to all the groups we are studying in this specific study. We then put all of these teeth through really large aggressive preparations, 5 by 5. In our first group in this study, we decided to do something different with our direct composite group. And that was using fiber reinforced composite from GC America, what we called Everex posterior, as our dentin replacement. Now, our bonding protocol was here done with Optibond FL, and the composite we used really was just a normal composite, regular field gradient direct. But what we were interested here to test with the direct group is how does this fiber reinforced composite affect this shrinkage that we've been looking at for years, and also the fatigue resistance and fatigue quality of the restorations. Something very important to know about fiber reinforced composite is that this material is not designed to be exposed to the oral environment. That's why for all these samples, we build our proximal walls so that we are taken into a class 1 situation. Then we fill up the bulk of our cavity with fiber reinforced composite. We leave 2 millimeters on the top, and then we finish it up with a regular direct composite restorations. Now, our second and third group are what we're comparing these restorations with, and that's our semi-direct and our indirect restoration. Now, for both of these groups, we run all the samples to what we call immediate dentin sealing, which is one of the most wonderful findings and basically givings of resin, immediate dentin sealing, which means right after we prepare these teeth, before we run them through temporization or bonding of our semi-direct or indirect restorations, we follow our bonding protocols here with Optibond FL, and we bond and seal only the dentin layer inside these restorations. We're going to talk a little bit more about this in the end and explore the advantages of immediate dentin sealing. Once all the samples for the second and third group go through IDS, then we start applying it. What do we mean by semi-direct? This is sort of a poor man's indirect restoration when we don't have access to milling machines. I used to do this in USC Mobile Clinic a lot back then. It simply means that you prepare your tooth like an indirect restoration, and you adapt a Teflon tape on all the surfaces of your preparation. Then you pretend as if you're doing a large direct restoration. This separation with the Teflon and the path of draw that you've created allows you to pull out this little piece that you have created in the semi-direct restoration. Then what makes this method very special is that you can simply put that piece in a little oven at 100 degrees Celsius, and that makes this piece do all the shrinkage it can. Then you simply deliver that piece just like an indirect restoration, and it will be as good as a milled composite restorations. So that was our second group, and we deliver it by conditioning it just like we would as if we are delivering a milled composite restoration. We delivered all these semi-direct restorations with preheated composite. We light cured it, we cleaned, and that was our second group. Our third group in this study is, of course, the golden standard, and that's the CAD/CAM restorations, the indirect restoration. Here, the blocks we used was the Serosmart from GC. We used the same bonding protocols. All the samples went through immediate dent in sealing. We milled perfectly fitted restorations to all the samples in this group. And again, just like the semi-direct, we delivered them with preheated composite. Now, this is a very intense study because we need to understand what's happening as far as shrinkage-induced cracks and also fatigue resistance. So for us to study the cracks, we transilluminated all these samples from distal, mesial, facial, and all surfaces of the restorations, and we wrote down specifically all the pre-existing cracks and all the cracks that happened during the bonding procedure, and 24 hours, 48 hours, and 1 week after all these bonding procedures are done. So we are really taking note of what is happening to all these cracks all around these restorations in all our 3 groups. Now, for the fatigue evaluation of all these samples, we use this monster machine called the MTS. This is the Acumen 2 system that we had at our research lab at USC. And what this machine is that it basically allows us to replicate the fatigue conditioning that this tooth would have gone through a mouth that is functioning in a really accelerated setting. All the tests are done in this chamber that you see underwater, and this cyclic rhythms just keep getting stronger and stronger until the tooth cracks. And the program and the machine allows us to keep track of the fatigue resistance and how all these samples are basically surviving and functioning under this pressure, this constant pressure that's being applied on the tooth. For the first time, what we saw in the direct group when compared to the semi-direct and the indirect groups was very different. We almost saw no difference in the way they performed compared to the semi-direct and the CAD/CAM, and that was fascinating. In fact, in our results, our differences was not significant enough for us to really have a strong occlusion. So what we decided to do was to run all these samples through what we call accelerated fatigue tests. This is just a chart from that old study from 2013, where we had really layered, heavily layered direct restorations compared to the CAD/CAM gold standard restorations. And we saw that early on, right when we start hitting the 600 newtons of force, they all start failing, these direct groups. And the indirect groups is just a monster. It really goes 100% survival up to all the way 1,400 newtons. So this time it didn't happen. And we said, you know what, let's cut all these samples on the functional cusp and load them until they just explode and fracture. And we really, that's going to allow us to understand how this fiber reinforced direct composites are performing compared to our semi-direct and indirect. Again, what we saw was very fascinating. For the first time, we saw that the direct group is really competing with the semi-direct and CAD/CAM inlays as far as fatigue. And the best news was that we saw that really most of these cracks are staying the same. We don't see a lot of cracks. This is an example of my weekends at USC School of Dentistry, because while these tests, the fatigue tests underwater are happening, we would actually film them with the underwater camera just to understand how they are failing and how they are exploding, so we can also study the retrievability. I will be really happy to share this article with all of you at the end. Since I'm not there in person, I promise that I will send a very useful handout that could become a little cheat sheet in all your dental offices after the lecture, I will email it to the organizer of the lecture, and I will ask them to share it with all of you, so you can really benefit from reading this article and having the what I would consider the most important slides in this lecture. So the good news is here, after incorporating this Everex posterior as the core of these direct composites, for the first time we saw that we can create large direct composite restorations that do not suffer from the C factor, the volume factor. So it's important that when we look at this checklist, we consider this as an option. We need to understand that when we are dealing with an indirect restoration, a situation like this that we looked at the beginning, maybe we'll tell the patient, you know what? This is going to be the price of Emacs overlay, but let's go through the carry screen layout. And if I feel really good about what's remained, then I'm going to try to do a fiber reinforced composite, which, by the way, needs to be charged very different than just a normal occlusal buccal surface or a three-surface composite restoration. You need to charge for this restoration correctly because it's time-consuming, it's technique-sensitive, and the material are costly. Here, it's really important for me to mention a few words that you will see at the bottom of our checklist here, and one of them is magnification. If you want to do a successful restoration here, magnification is extremely important. Here we're using Carey's disclosing agent after we remove that big amalgam so that I can tell the difference between the secondary dentin, affected dentin, and infected dentin that really needs to be removed. I like to use the Carey's disclosing agent from Care. It's a pink solution that really helps me in my everyday dentistry. And the utilization of electric handpiece is really the reason why I can work those diamond burrs really slowly and remove only what needs to be removed and not aggressively go in and end up with a tooth that then may need a root canal and a post and a crown, which I think then is the circle of the death for this tooth. So this is what we did. We used our caries disclosing agent with high magnification here. This is exactly how I can see the tooth through my loops. On my everyday dentistry, I'm using 8x loops from Surgitel. I know it's insane to think about wearing 8x magnifications on a daily basis, but trust me, when you go there, there is no way you're going to come back. It's addicting, and you will feel that you will not see if you're not using your loops. So here, I'm in a situation where I feel pretty good. I say, I have fiber reinforced composite. I have a study that proves it. I'm going to go for it. And then I tell the patient that, hey, you're not going to pay the amount of money that we expected to pay for an indirect restoration. It will be close to that, but we can do something much more conservative here. And just think about it. If I wanted to do an overlay here, I really would have had to take care of this cusp, take out this cusp just to get that pass of insertion, and I would just lose this precious tooth structure. A reminder that fiber reinforced composites need to be encapsulated because of how rough they are. They're not designed to be basically used and exposed in the oral environment. So just with our composite here, I'm using GC Accord for our restoration. I build a facial wall, and now I'm left with a regular class 1 situation. Then I use my fiber reinforced composite. Here, I'm not using the Everex posterior. GC America came with another form of fiber reinforced composite, which is called Everex Flow. It's a lot easier to apply this material. The difference is that the length of the fibers are not as long as what you would have in Everex posterior, but you have more number of fibers. I absolutely love this material. It has a really nice color of the dentin. It gives you that concave shape of the dentin. So I apply that here. This is after polymerizing my fiber reinforced bulk. Just like we did on this study, I leave the occlusal 2 mm now for completing my restoration here with my enamel shade. Here I'm using the JE from the GC Accord system, and I love using a brush to adapt these cusps carefully. And here we're really going all out with what our direct composites can perform functionally and from a shrinkage perspective. So why shouldn't I spend the time and make this composite restoration as beautiful as an indirect restoration? This is my chance to now be a little technician inside the mouth of my patient. So I really go for it. I'm using a brush. I really carefully layer this enamels, and I use stains to really do these nice internal stainings. And now I'm able to create this direct restoration that is not suffering from the C factor or the volume factor. And I feel great about it. And I feel great to charge much more than what you would have charged for a 2 or 3 surface direct restoration. So keep shrinkage in mind and understand that when you have fiber reinforced composite in your toolbox, you can perform a lot more than you think with direct restorations. Now let's talk a little bit about another study here that we were really excited to do at USC back then, when we were really looking into this direct restorations, because we wanted to perfect it. We wanted to make sure that all different components of direct composite really goes as close as the quality of the golden standard, the indirect restoration. And one of the big problems were these interlayer gaps. A lot of times when we do direct composite restorations, we see these bubbles. And I'm pretty sure if you've done class 2 restorations and sometimes you remove a matrix or the neighboring tooth gets extracted and you get a nice view of these proximal of the class 2s, you see these bubbles. Or when you're removing old composite, you see these big gaps or big bubbles within direct restorations. This is a big problem. If you have these big bubbles, then it definitely affects your large direct composite restorations from a fatigue perspective. And that's what we're looking at here in this study we did at USC. We're using typodon plastic teeth here because we simply wanted to make sure all the samples are exactly identical. And we're dealing with class 2 composite restorations. So we created 2 groups. First group and second group use 2 layers of composite. The first group, and by the way, all these groups are given to students at USC. This is performed by students at USC School of Dentistry. We give them the same situation, but group 1 only gets instruments and they get to do interlayer wetting. And that means just wetting between the layers of their composites with a microbrush before they apply and right before they light cure each layer of the composite. The second group, on the other hand, get composite instruments only. They don't get interlayer wetting. They don't get to wet in between their layers, and they just get these good old composite instruments, and they get to pack their class 2, and they light cure it, and they finish it as best as they can. Now, let's look at group 1 again. What do we mean by interlayer wetting? That simply means before each layer of composite, we wet our microbrush in our adhesive here in Optibond FL, and then we apply the composite layer. And the idea here is that because this layer underneath is wet, it really helps the adaptation of all these layers of composite, therefore decreasing the amount of gaps in our overall class 2 restoration. Then we take all these samples that we collected from both groups and we look at them interproximally and internally. Before we section them interproximally, we put all these restorations on a grid and we just put a red dot on every cube that has a little void or a little gap, which, believe it or not, are very common in class 2 composite restorations, especially if you don't spend enough time really hacking your composites well. And we count them. Then we section all these samples in 1 mm slabs, and we put all these slabs again in the same grid. And we count and put a little red dot in every cube in these bisects where we see gaps or voids. And we do some simple calculations. And what we found out was very interesting. Group 2 that used instruments only had a much higher percentage of gaps than group 1 that did interlayer wetting. So it's really, really important to consider everything that can help you get a better adaptation of all these layers of your direct composites when you're performing one. Consider interlayer wetting. Again, it means right before you apply each layer, you get a really thin layer of your bonding agent or your modeling resin. You wet the surfaces where you're about to apply your composite layer. And the idea is that that helps this composite sit and adapt really nicely to all the walls of your composite. Now, the second component of this perfect adaptability of your composite is using composite heaters. This is a must if you want to consider yourself biomimetic dentist. This is a very simple composite warmer that I like to use. It's from Adent Dental. There's many composite warmers now on the market. There's composite guns that warm the composite while it's holding the carpule. There's many different ways to do it. I really recommend that you get it. This exists in every single operatory of my practice. And if we have a composite or even a build-up appointment, all the composites are constantly being warmed up, and you will see that it will completely change the way you handle your composites, and it will significantly reduce the interlayer gaps of your composites.